It's Rob Casquejo in the Dermcast studios again with Dr. Arash Mostaghimi today, and we're very happy to have his expertise here today. Welcome, Dr. Mostaghimi.
Thanks for having me.
All right, so you supported us at the SDPA Summer CME Conference, and we appreciate that very much. First of all, thank you for sharing your academia with us, because we can only get better with with good academicians instructing us. So thank you for that, number one.
My pleasure.
All right, and you had multiple lectures, so we can talk about a few things today. I'm going to start by letting you just give your backdrop a little bit and sort of boost yourself a little bit here.
Thank you. I'm Arash Mostaghimi. I'm an associate professor of dermatology at Brigham Women's Hospital, Harvard Medical School. I take care of patients in the inpatient and outpatient settings. I spend about half my time doing research.
All right. So obviously, you're published. You're in a very strong academic background. So we'll talk about these topics in context of everything that you do. But let's start with alopecia areata, because I know this is something that you're particularly passionate about. Can you tell us why?
Absolutely. So remarkably, like every dermatologist, I learned all about hair loss. I learned all about treatment of alopecia areata and what best to do with those patients. I'm embarrassed to say I didn't really understand the disease or its impact until my daughter developed alopecia universalis at age 5. So when that occurred about almost 10 years ago now, I changed the focus of my research onto alopecia areata. And as we'll talk about, it's been an incredibly exciting time to be part of the alopecia areata landscape.
Because there's a lot of things changing in therapeutics. And so that's a great story, by the way. I mean, this is, I see a Hallmark movie in here somewhere with this. So we're getting some wins in alopecia areata. So why don't we talk about what's new, what's newish, and what's coming in alopecia areata? And let's start with systemic therapies that we know we've gotten recently. Talk to us about that.
So we're in a amazingly exciting time for the treatment of alopecia areata. So the JAK inhibitors have become a mainstay of treatment for alopecia areata. This is an offshoot of research from about 10, 15 years ago that showed that the JAK-STAT pathway was elevated, its activity was elevated in patients with alopecia areata. And so the first drug that came to market, the first FDA-approved drug for alopecia areata was baricitinib, which was introduced about a year ago in the summer of 2022. But what's most exciting is that our second drug, ritlecitinib, was just approved as of our day of recording yesterday, so one day ago in June of 2023.
That's amazing. So we've got the JAKs. So then we know that we've got JAKs we can use. What is coming in terms of JAK therapeutics?
So the exciting part about JAKs is that they give us our first FDA-approved medications for alopecia areata. They're a very good start. They work about 30 to 50% of the time, depending on the patient and depending on the study that you're looking at. And by work, I mean that it regrows a cosmetically appropriate amount of hair. There still is a long way to go in terms of speed of onset and having more complete response in more patients. The other challenge with JAK inhibitors is that once you start taking them, you have to take them in an ongoing manner, otherwise your hair is likely to fall out. So the things that remain with drugs that we already have, we don't really know the utility of adding oral minoxidil or topical minoxidil to JAK inhibitors to say how they work together. This is commonly done in practice, but has never been studied rigorously. The second thing that is coming is first, new JAK inhibitors. So deruxtelinib is a drug that is likely coming in the first half of next year. It's a slightly more potent JAK inhibitor. And then what's most exciting is that there's a whole series of studies right now in phase 2 and early phase 3 looking at completely novel mechanisms for treating alopecia areata.
Wow, that's great. So we still got a lot of things coming through research.
I think for those of us who are older, you can think back to when Enbrel first came out, when Humira first came out, and what that did for psoriasis. It was transformative. And look how far we've come since then. So I think we're in a similar boat now.
Well, and we could use the help because there's not a lot of slam dunks in alopecia areata, especially the more advanced cases.
That's right.
That's fantastic. So we'll talk about now. You lectured quite a bit on dermatopathology as well. You did a series of lectures on dermatopathology, particularly from a clinician's standpoint, which is very useful because most of us are not reading slides. We're getting them from a pathologist. So there's this relationship of we do the tissue, they read it, and so we've got this team-based effort. So let's talk about our biopsying methodologies and how it applies in our practices. So is there ever a time that you would choose to not biopsy? Would you advise, even as a clinician, that you shouldn't biopsy in X amount of situations?
Sure. So, biopsies is kind of like pizza, right? Papa John says better ingredients, better pizza. You get better tissue, better place to start, you get better results from your biopsy. So the times that you should biopsy are times in which you know that getting a biopsy, obtaining that information is going to change what you're going to do on the other end of it. So that means you're either going to rule something in that is interesting, or you're going to rule out things that are bad, and it allows you to proceed. The only time you should not biopsy really is if either the biopsy result is not going to help you, right? Or if you're just doing it out of habit. You should really pause, think, okay, I'm doing this test. Why am I doing this test? Why am I doing it in this patient? Why am I doing it right now? And when I get this result back, how will that advance my care of the patient? As long as you're thoughtful about it and appropriate, there are parts of the body that are more sensitive or less sensitive, more aesthetically complicated, less aesthetically complicated to biopsy, but there's no strict contraindication. If you need to do a biopsy, you can do a biopsy.
Right. So let me ask it in context specifically of anatomy, regional anatomy. Name 3 places where you should be really cognizant of regional anatomy in terms of biopsying and potential surgical bad outcome.
Sure. So the body, and usually at the superficial level that we are biopsying, is pretty forgiving, fortunately, and things heal well and do well. A couple places that you need to be careful are if you're doing punch biopsies along the temple, you need to be careful about the temporal artery. So you need to be thoughtful about your landscape and how deep you're going and why you're doing that. A second area would be on very thin skin, like the eyelids, for example. You can definitely biopsy on the eyelid. You can definitely anesthetize the eyelid. The 2 things you have to be careful about is, first, you have to do patient selection very carefully. If they're fidgety or moving, you have to be careful with it. Sometimes they may need an eye shield, but if they can hold still, you can do it without that. And then secondly, you have to be really, really careful with the depth, right, of your biopsy, which sounds obvious because the skin is so thin, but you really have to be thoughtful around that. A lot of people worry about healing with the eyelid biopsy. It heals perfectly, right? It's a beautiful place to heal by secondary intent. And although it can bleed a little bit, it can be a little bit annoying at the time that you're doing it, patients often do well. And then the last place that you should be really careful about is anything on the lower extremity, anything below the knees. So things farther down in the body take longer to heal. They're more likely to get infected. And particularly that's doubled in patients that are older, who are often the patients we're doing these biopsies for. So when I do biopsies in those areas, particularly if I'm doing it for non-melanoma skin cancers or keratinocyte carcinomas, you don't need to remove the whole lesion with your biopsy. You just need a small sample, a partial sample, so you can get enough information to know what to do with the next step. So if somebody has, let's say, a 1 centimeter, 2 centimeter basal cell on their leg, I don't need to do a gigantic deep shave if I know I'm going to send them to Mohs or send them to another procedure afterwards. I just need a small biopsy, enough to get me that diagnosis, that biopsy information plus my clinical assessment confirms it's a squamous cell, basal cell, what have you, and then I can move them on to the next step and not leave them with a large painful ulcer or bleeding ulcer while they're waiting for the next surgery.
Okay, so let me parlay that last point you made. Is there a time when you should not do partial biopsies?
Mm-hmm. So in general, if you have a pigmented lesion that is heterogeneous, you should try to take off as much of that lesion as possible, right? So if you have a funny looking mole and you biopsy part of it and it comes back normal, it doesn't mean that the rest of it is normal, right? So this is a time in which broad-based shave biopsies can be super useful. You're focused more on breadth, not as much depth, right? You don't need to get super deep with these, but you can take larger pieces of tissue that can be analyzed thoroughly. There's been a lot of information suggesting that although you may look at let's say a large mole and say, okay, this is the weirdest part of the mole, I'm going to biopsy that. When you look at the mole overall, it may be that the more concerning parts are not actually linked with what we see on dermoscopy or clinical evaluation.
Right. And then let's parlay that a little bit further. What are some of the biggest pitfalls in biopsying, doing skin biopsies for any kind of lesion, whether they're malignancies or not, rashes even?
Yeah. So the biggest mistake that people make is if you are not thoughtful about what you're biopsying and why, you're more likely to do a biopsy that's not going to give you the information that you need. And what I mean by that is, an example I gave in my lecture was that you have scaly dermatoses that are clearly in the epidermis. Those are pretty easy to get to. Sometimes you have less scaly, deeper things that are going on in the dermis, and then you may have a suggestion that you have a paniculitis or deeper inflammation that you're dealing. For example, if you have a paniculitis and you do a punch or shave biopsy, well, if the action is deeper, you're not going to get the information that you need from that. So although it may be a bigger procedure up front, maybe a wedge biopsy, maybe a deeper biopsy, for example, you'd rather skip directly to that than cause a trauma, cause a discomfort, and do something that doesn't give you all the information that you need. So it's a little bit of sort of preemptive clinical pathologic correlation. You probably don't know what it is. You may not know what it is while you're biopsying it. But based on the physical signs and symptoms that you're seeing, you can predict what exactly is going on in the skin and how can I make sure that my biopsy matches what I'm trying to find.
Got it. So basically what I'm hearing there is it's really the depth, let's say, of the biopsy is directly dependent on what's going on clinically. Is really what
that's exactly it. I think the big picture is that we do things like biopsies so many times that it becomes just like a fleeting moment in our lives. We don't even think about it, right? It's so routine and automatic for us. And often we just fall into the same practice pattern over and over and over again. So if you ask, why this patient, why this treatment, why right now, and you can answer those three questions, you may find that, okay, 98% of the time, 95% of the time, you're doing the same thing over and over and again. There may be that 2 to 5% of the time where you're like, hey, I'm going to do something different in this patient for this reason. Either I think the rash is different, or the patient's situation is different, or something else is going on that encourages me to do things differently. So really just having a population level based thoughtfulness about it, but when you're treating a specific patient to prioritize the strengths and benefits of that treatment in that one patient.
All right, great, that's fantastic. So thanks a lot for all these practical points that we can apply to what we're doing every day. So let's do this. Let's end off with a little bit of tennis here. I'm going to lob some questions at you.
Pickle ball.
Yeah, right, pickle ball. And probably not even things. Pickle is a big thing out west right now. I don't know if it is
here
back
too.
east. Okay,
Yeah.
All right. So I'm going to throw a question at you, and probably unrelated questions. You can just give me your short version answers, and let's see if we can't come up with some stuff that's relevant for our viewers. Okay.
Go for it.
All right. So first question. You gave a lecture on sort of the state of medicine and kind of what we all have to deal with in our current practice situations. And you mentioned prior authorizations. So what is do you have a go-to resource for form letters for prior authorization?
So you can definitely expedite this process. You don't need to do the same thing over and over again. There's two options. One, if you have a good form letter that you've written yourself, just save it as a dot phrase or something similar in your electronic health record, change out the facts and use it, right? A second option is the American Academy of Dermatology has a wonderful resource for prior authorizations where you can look it up by disease and by drug, and it asks you specific questions, you fill it out, and it generates an automatic letter that you can then cut and paste into the electronic health record and then also send to the insurance company.
Okay, great. And let's turn to dermatopathology. Let's say true or false, you should always do a full thickness biopsy on a pigmented lesion.
True, but with a caveat, you should always try to do one. So your goal should be, if you think the lesion is deep, you should try to get deep enough that you can get to see how deep a pigmented lesion is, because if you have a melanoma, for example, that's very important. That said, it's not the end of the world if you do a shave biopsy and you transect it. There was a study that we presented in one of our lectures that shows that even when transected, on a subsequent full excision, only 3% of patients had a different outcome than what they had from the initial information from the shave. So if you are going to have a delay or sort of big procedure to do an excisional biopsy on a lesion, let's imagine it's on the face or a sensitive area, go ahead, do the shave, try to do it deep enough, a millimeter or two is all you need to know how deep it goes so you can make that decision about what to do next. And then from there, if you need another excision, you can do that as well.
All right. True or false, a pigmented lesion should always get a full thickness biopsy?
So it's true that you should always try to get a full thickness biopsy on a pigmented lesion, but it's false that you don't always have to. And what I mean by this is don't let perfect be the enemy of good. The old days where you do a full thickness excisional biopsy, first will be overkill on benign lesions, and second may have cosmetic or time delay, cosmetic outcomes that you don't like or time delays in getting that information. What you can do instead is you can do a broad-based shave, not superficial. You can do it a little bit deeper. If you go 1 to 2 millimeters deep, you can usually get the vast majority of lesions. If there's some pigment left at the bottom, that's okay. We reviewed a study in one of the sessions that showed that even among transected lesions, only 3% of them upon full excision had additional information that changed either sentinel lymph node or staging. So in the vast majority of cases, you can get all the information you need with a good shave biopsy.
Okay, so pigmented lesion assays, genetic profile type testing, the sticker variety, is an accurate test in lieu of tissue biopsy.
Maybe. I think the jury is still out. In some patients, the use of the sticker test to look for genetic variations can certainly provide value or added information. I think the hard part is that I struggle as a clinician for what is a mole that's abnormal enough that I want to do a sticker test on, but is not so abnormal that I want to do a biopsy on. And biopsy is so much more definitive, is so much more conclusive, and is the standard of care that it's hard for me to rely on that middle test. So for me, the vast majority of the time, I either imagine this lesion is benign, I don't need to do anything, or I need to biopsy it and remove it. There may be some very cosmetically sensitive or other areas that you may want to use a sticker test in, or patients that are very resistant to biopsy. But in general, those sticker tests are not a main part of my practice.
And is it long-term outcomes that are lacking, which makes it jury's out? Is that really what it is?
I think the real question for those tests is, am I going to end up doing the same thing I would have done anyway, right? And how reassured am I by this? So if I really saw something and I felt it was truly an abnormal lesion, and the sticker test came back benign, think for yourself as a clinician, do I feel good enough about that I'm not going to do it? Right. I feel for most people, if they think it's benign, the test shows it's benign, they feel good. If they think it's a concern and the test shows it's benign, they're still going to take it out. So I struggle with this place in clinical decision making.
Okay, got it. Okay, and an atypical pigmented lesion, let's say nevi or otherwise, that are not malignancies, should all be pursued with surgical treatment to achieve clear borders.
So false. This is something that has changed. We have great data for it, and standards of care have changed. So historically, it always changes how they grade nevi, but historically it's been sort of a mild, moderate, and severe version of these nevi. And the data is very clear for mild and moderate lesions that surgical re-excision of lesions that have positive margins neither do they identify lesions that were melanoma where you just got the regular part of it. That's exceedingly rare. Nor do they prevent long-term outcomes of these lesions transforming into something worse or more uncomfortable or more dangerous. So you certainly don't need to do it for that. I mean, in real life, is the chance zero? No, nothing is guaranteed, right? Nothing is 0%. But standard of practice in terms of what's best for patients and in terms of what medical legally works, you're in a very strong position there. The data increasingly suggested that even for severe nevi, severely atypical nevi, a watch and wait approach for positive margins may be appropriate in many patients. This is still debated. It is still an area where the standard of care is evolving. What I do is in those patients, I have a conversation with the patient about the decision making and what it means. If it's a cosmetically sensitive area and it would be a large excision, it may make sense to wait and see. If it's something small and a regrowth would be more annoying because you can't tell if it's abnormal or how is it, it may make sense to just go ahead and do the re-excision at that point. But overall, the more data we have for all of these, it suggests that atypical nevi are not the same as melanoma. And we shouldn't be, we have lumped them together like they're stops along a train onto the last station being melanoma. That's not entirely the case.
Okay. And all melanomas less than 0.8 centimeters should have genetic expression profiling.
This is, it depends, I think, and this is really an evolving area. I think there's some debate as to whether the genetic profiling can help triage these into higher risk melanomas or lower risk melanomas. I still think that for the vast majority of these, the risk overall is so low with such a thin melanoma that complete excision is the most appropriate path to take. And standard genetic evaluation, while it may have a role in the future, is still not standard of care that we need to approach here.
Thanks a lot, Dr. Mostaghimi. This is really good information, and I'm sure that our viewers are going to be able to apply a lot of this into their daily practice. So thanks a lot for coming and for sharing and supporting the SDPA and sharing your academics with us.
I really appreciate that. Your chair looks pretty good. I may be wanting to sit in it next time.
All right, okay. We could use some help at Dermcast all the time. So, let me know. Well, we'll see. I'll see what I can do. I'll run it up the ladder. All right.
Thank you, Rob.
Yeah, thanks again for coming and supporting the SDPA.
Okay.
Once again, it's Rob Casquejo in Boston, Massachusetts for Dermcast TV.